Welcome everyone to today's webinar. I'm Molly Gamble with Becker's Healthcare. We'll begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. At this time, it's my pleasure to start today's webinar by introducing our presenters. James C. Miller, CRNA, MS, MBA, is Vice President of Operations and Perioperative Services at Lehigh Valley Health Network, based in Allentown, Pennsylvania. He joined LVHN in 2002 as a certified registered nurse anesthetist. Jim began his leadership journey in 2005 as Network Director of Anesthesia and Perfusion Services, where he led a number of quality and process improvement initiatives that brought distinction to LVHN. Since 2016, James has provided the clinical and operational leadership for all facets of Lehigh Valley Health Network's comprehensive perioperative and endoscopy services program. Within this role, Jim is accountable for organizing, directing, developing, and implementing a strategic vision, effective programs, efficient services, cost reductions, service enhancements, quality initiatives, and productive relationships across the surgical continuum. LVHN performs over 60,000 surgical and 15,000 endoscopic procedures annually. Jim holds a Bachelor of Science degree in nursing from Holy Family University, a Master of Science degree from St. Joseph's University, and a Master of Business Administration from DeSales University. Jim is a graduate of LVHN's Institute for Healthcare Leadership and currently serves on a number of LVHN committees and boards. Martin A. Martino, MD, is a gynecologic oncologist in practice at the Lehigh Valley Health Network since 2005. He is a professor of obstetrics and gynecology at the University of Southern Florida and a member of the departments of OB-GYN and surgery at LVHN. He completed medical school at Hahnemann Medical College in 1998 before going on to complete his residency at Rutgers Robert Wood Johnson University School of Medicine in New Brunswick, New Jersey in 2002, as well as Galloway Fellowship at the Memorial Sloan Kettering Cancer Center in 2000. Dr. Martino completed his gynecologic oncology fellowship at the University of South Florida H. Lee Moffitt Cancer Center and currently serves as the medical director and chief of the minimally invasive robotics program at LVHN. For those who know him, his passion is in his caring for patients and bringing them the most advanced innovative tools to help them get well. In 2008, he started the LVHN Robotic Surgery Program, where he has completed nearly 2,500 robotic procedures. Under his leadership, LVHN has completed nearly 20,000 procedures across 11 service lines, 6 hospitals, and more than 50 surgeons in northeastern Pennsylvania. He is a founding member of the Institute for Surgical Excellence as well as the Robotic Training Network. He also developed the first app in the iPhone store called Robotic Surgery, which is freely available for standardized education and training for future physicians. At this time, I am pleased to turn the floor over to Jim to begin today's presentation.
Hey, Molly, thank you so much for having us today, and welcome everyone, and hopefully we live up to the bios. But Dr. Martino is going to kick it off today.
Thank you, Jim, and thank you, Molly, for that introduction, and to everyone for joining us. We've been doing something special here at Lehigh Valley Health Network in Allentown, Pennsylvania, and over the course of the next 35 to 40 minutes, we're going to describe that to you, and then at the end, we look forward to answering any questions that you may have. To start with, as we develop any strategy, it's important to have a vision. So our vision is very clear: to build on our position as the premier unmatched leader in the multi-specialty surgery space in robotics. And we focused on the quadruple aim, as many of our institutions do, looking at quality, access, value, and experience. Really fostering innovation, creative education, and necessary research on our milestones and our missions. Fortunately, we've also been recognized at LVHN by some of the leading centers in the country as well with our work. So to describe our robotic surge service line overview, we have 11 specialties now, and we didn't start that way, but we do today, and we'll talk about that. We also have 54 Da Vinci trained surgeons and currently growing, and 11 platforms within our network. Again, we're in northeastern Pennsylvania, and these are our 11 service lines across bariatric surgery and urology, thoracic surgery, colorectal surgery, reproductive surgery, and really the foundation being general surgery and gynecologic oncology. We're looking forward, Jim, to approaching 20,000 cases as well in the very near future. As we think about our volume and when we started this journey, this is in 2008. And you can see here, if you look where we started with was with one S. And that S system has helped us to transform our community, to provide better care for our patients. Early on, as one of the surgeons starting this program, you can see in urology and GYN oncology, we started slow, we were thoughtful, we measured our outcomes, and we slowly grew until 2020, where you can see now we've expanded our fleet to 4 Xi platforms with 2 Xs. We have 1 SP that we can discuss, as well as 4 SIs that we're continuing to work with. But the volume has grown. And there's a little downtick you can see with COVID, but certainly it's continued to increase as well. And to date, we are at 19,000 plus procedures that we've done, really taking care of our community. And that's the most important thing that we're able to do here. I'm going to turn this over to Jim now to really discuss how the site of care strategy has been developed.
Thanks, Marty. So the main question all along for many folks on the line and watching this today is why robotics? And I think in the audience today we probably have people from, skeptics to all-in supporters. And I will tell you that I've probably throughout my career ranged from that role of skeptic to now all-in supporter. And my intuitive colleagues know that this did not happen overnight. And as Marty said, we were very measured at the beginning of the program. And as we've grown, we have not changed that focus. So everything that we do at LVHN really focuses on that quadruple aim, and it's very measured in its approach. And we often test, why we're doing things. So it's important for us to always ask, why robotics? This is and for the majority of today's talk, we're going to focus on the core Lehigh Valley facility of Cedar Crest, which is our level 1 trauma center. We do all specialties here, including kidney transplant, neurosurgery, heart surgery, a ton of trauma here. We have a very robust bariatric program, surgical oncology program, gynecologic oncology, and this is where the majority of our Da Vinci systems were used from 2012 through 2017. What you can see here is in 2017, we had 2 systems and later went to a 3rd system. But based on volume, we're around 1,200 cases for the year. That's maximum utilization of the system based on the procedures we were doing. We did very little minor surgery, very little general surgery. It was mostly complex prostate, malignant gynecologic oncology, surgical oncology, thoracic surgery at this point. Again, we used the quad aim as our guidance, looking at patient experience, better health outcomes, improved staff experience, lower cost of care. And initially, and this is where my skepticism changed and I became a supporter, is we were able to achieve all these with the assistance of the robotic technology. We also focused on growth and access. And the one thing that we found out is that while, Dr. Martino, myself, my team, Alex Warman, Hope Johnson, and many of the people, the surgical leaders across the continuum, they were all in. But we knew that we had a disconnect at a surgical level from a leadership standpoint and from an executive level within our C-suite. So the vision of the robotic leadership team, and this was enhanced by a newly formed institute. In 2017-2018 timeframe, LVHN went into an institute model and launched 3 institutes. One of those was the Institute for Surgical Excellence, which is within Lehigh Valley Health Network. And we made a promise to really focus on clinical differentiation in the market and focused on growth in all volume and procedure types. I apologize, we're having a little bit of a technical difficulty here with our slides. All right. So late in 2017, the team from Lehigh Valley Health Network, including Dr. Martino, myself, the administrative team, as well as the newly announced leaders of the Surgical Institute, went to a peer-to-peer meeting in Philadelphia. We arrived there, interacted with some great representatives from Intuitive, and listened to many of our peers in Pennsylvania and beyond talk about their programs. So this allowed us to figure out where we were, where we wanted to grow, and the why behind that. In addition to that, it allowed us to take a step back and really develop a 90-day plan as a team. This was the second part of the day and really carried on into the upcoming weeks and months following, where we looked at standardization of our service lines. We looked at a block strategy across the entire network and really looked at where are we doing our surgery, where do we want to grow, and what's the appropriate location for that surgery. As I stated earlier, we did a lot of complex surgery at our Cedar Crest campus where we felt that we were maxed out. But we wanted to evaluate the part of the strategy as we grew the program and as robotics evolved into general surgery, hernia, and some lower acuity surgery. So coming out of the 90-day plan was born our operational strategy as an institute program and a robotics program across LVHN. Our goal and focus was to establish a center of excellence for robotic surgery, provide increased and timely surgical access to robotic platforms, and that married up with our service promise to our patients, and that is delivering on today, tomorrow, or the next day. That's from an office appointment to a surgical appointment. It was a little easier back in 2017, 2018 without all the insurance pre-authorizations and other things, but this was one of the overarching goals that we had in mind as we developed this operational strategy. We wanted to develop a world-class center for robotic education and training, as well as implement, where necessary, enhanced telesurgery capabilities, and that was all part of this 90-day vision. We developed an aggressive and comprehensive marketing strategy to really highlight our leadership in the robotic surgery space in the region and beyond. So, as part of this evolution, we knew that there was a disconnect, as I said. Not everyone in the entire network were complete supporters. So what we created was a connection from the C-suite, and I apologize, this is not going as planned with the animation here. But the connections from the C-suite to the Robotic Leadership Committee went from the C-suite to the Institute for Surgical Excellence, which is in this middle frame, operational and clinical leadership, Dr. Martino and other surgical leaders, and that really empowered the robotic leadership team to think differently about the future and really launch on a new journey, how to expand this in a fiscally responsible way and provide a really site of care strategy. So moving away from that 90-day plan and with the assistance of the Institute, we were able to standardize our platforms at our Level 1 Trauma Center where the most acute cases were going to fourth generation technology. This is all viewed, as you see, was progressed through these steps, almost as a pilot. We upgraded fourth generation technology. We provided some access to general surgery at the Cedar Crest campus. They were a very small player at that time, and we increased their access there as part of the pilot. Began analyzing and tracking benefits of hernia procedures, and I'll go a little more into that as we move forward. Then what we were able to do is, as we upgraded to fourth generation technology, transition one of our third generation platforms as part of this continued pilot to our 17th Street ambulatory surgery unit. This is predominantly day surgery, about 99% day surgery, with a length of stay of less than 6 hours from time in the door to discharge. And this was a good opportunity really to look at, can we decant those higher volume locations and take those low acuity procedures that may be an area of focused growth and move them to a lower acuity campus and begin doing gyne procedures as well as hernia procedures there. We trained additional surgeons, team members, all at the 17th Street campus. So what did we find? So remember, our goal was to increase access, increase patient outcomes, improve provider satisfaction. So that's what we found. This ties nicely into the quadruple aim, as we said. And then when I walked through these boxes, we did pain surveys with our patients in the general surgical space to ensure that what we found in our Epic records and our analytics team was looking at lower postoperative medication, lower prescriptions, lower filled prescriptions, and then we actually did the tally with the patients and looked at their pain scores postoperatively. And we found that, one, they were using less pain medication, and two, had enhanced outcomes from a pain perspective. When this program was launched at 17th Street, we did the majority of our hernias open, and only bilaterals were done at that time with minimally invasive, but that was laparoscopic. It was not robotic at the time. With the support and buy-in from our surgeons who did general surgery and hernia surgery, and some key champions, as well as support from our colleagues at Intuitive, we were able to figure out that converting to that offered us higher reimbursement, and we did this with cost neutrality, or even in some cases with benchmark surgeons, reduce costs. Robotic technology took a lot of the complexity about case scheduling accuracy out of it for our general surgeons, and we provided consistent OR times and very accurate timing, and that goes to the physician and provider satisfaction standpoint. We provided a more efficient environment, and that allowed for improved growth and access. At the end of the day, we also tied that together with our patient satisfaction scores for that campus, and we saw that not only was there not a deterioration of that, there was actually an increase in the patients that we surveyed. So this is where it's important. Building a program and building a strategy is great when you put it down on paper, but how do we achieve that strategy? And we focused very hard and in a very, very strategic way to work our way at every level through the pillars to make sure that we had success. We took it level by level, strategically, as I said, and we gained buy-in group by group. We worked with operational leaders, we worked with clinical leaders, and we worked with the executive leadership team. We had to validate and support each other. We had to validate and provide evidence along the way. And at the end of the day, we were able to gain clinical buy-in. We were able to get our IT colleagues and technology colleagues, our physician practices, they were such a key part of this, really to buy in and support. And then with the help of the Institute leadership, we were able to work with our executives at the C-suite and make sure that we had achieved what they needed out of the business planning. We put here gaining alignment within the Institute. Our Institute for Surgical Excellence at Lehigh Valley Health Network is comprised of surgical leadership at the highest level, innovators, surgeon leaders, operational leaders, vice presidents, marketing, information technology, our telehealth team. There's really representation from everything, and it brings it together. And what that does is it allows us to move through the business planning process a little easier, gain alignment, and gain support moving forward. So how do we get executive buy-in? One, we guaranteed that we would continuously differentiate ourselves in the marketplace as a true leader with this technology. We focused on growing volume, and this was really important when we looked at this. We are not just growing robotic volume, because that's called shift. And at the end of the day, if I'm the CFO and this was his drill to us, prove to me that over the years, as you've grown robotic volume, that you continue growing surgical volume in those same specialties. So is this paying off? And what we found is that we had equivalent growth or greater growth overall in those specialties because of the robotic technology. And most importantly, from a CFO perspective, we wanted to make sure that we had financial viability moving forward and a reduction in the total cost of care. We know that we're going to spend a little on the direct supply cost, but if we have improved outcomes, fewer readmissions, decreased length of stay at our higher acuity centers, that we're going to win the total cost to treat.
That's great, Jim, and thanks for laying out that operational strategy. Living this journey with Jim has been remarkable, and really congratulations on helping us to put that together. As we shift now to the outpatient strategy, we'll move ahead, and we had to decide what solutions could we provide to create more access. As you've heard, at Cedar Crest, our hospitals were full. Our ORs were being full. It was challenging back in the 2017-18 time period to bring patients to that service promise. And our CEO and C-suite said, this is your service promise. Today, tomorrow, the next day. Take care of patients in your community. And that was the dictum that we were given. And we, as a group, said we strive for excellence. We will do our best to do this. And that's when we said we have to do better. So the solution we said was, let's look at additional platforms. And as you can see here, at Cedar Crest, we had two systems. They actually were SIs. And what we did is we upgraded the SIs to XIs and shifted one of the SIs over to 17th Street. And we validated our model. We tested this as well to see how this would work. Soon we added an XI as well as an SP, which was and is the first in the region to be able to offer this. And that allowed us then also to add two Xs. So now in 2020 we have three XIs and an SP, so standardization of the fourth generation platform, as well as two Xs at 17th. And this has been a game changer. As we'll talk about, this has really been remarkable with the tools, the technology, the innovations that really is exciting as it continues to evolve. So what's the value of a robust site of care strategy? Well, what we've been able to do is shift these low acuity cases to an ambulatory setting. As we've identified, we've seen hernia cases and benign, simple gynecologic cases that may not have been so simple before, but now with these tools, simply we were able to identify them. They were at a short length of stay, work with our surgeon colleagues to shift them to our 17th Street site. We've been able to decant the main operating room at Cedar Crest. Once we did that, now we have the higher case mix index procedures, the patients we can bring, provide them access to the important care that they need. We've increased surgeon alignment. Our teams have been working together since we started. That was part of bringing surgeons onto our team. We've leveraged our platforms. This has certainly helped with recruitment and retention. And during this time, we've been able to recruit a thoracic surgeon, as well as we're preparing for the future of lung cancer surgery again, which will revolutionize the care that everyone on this call will be able to really help shift that overall survival with lung nodules. We've been able to capture new revenue streams. Without question, we've helped to consolidate the market. Patients come from miles and miles away and drive ancillary growth. And throughout this, we've lowered costs to our payers and our consumers. Now, how to do that? Well, in our network, and we've been able to prove this, that quality care costs less, better care costs less, and that's what we've been able to do with this technology. And throughout this, we've maintained and actually grown surgical volume. As far as the structure in our leadership, we've developed this through a multidisciplinary approach where we have at the core all of our team members on our nursing team, our surgeons, our learners, and our residents and fellows, and others. We said, let's get involved. Let's be a part of this. So we formed committees. At the basic level, we formed a robotic education and credentialing committee. We have first assists who are physician assistants who are part of these committees as well. That's part of our first assist program. We've established a QA and PI committee as well to align with both our departments of surgery and OBGYN and our network QA department. Within this, we have added data analytics, video review performance platforms as well, and this has allowed us to help to look at different opportunities for credentialing and re-credentialing. We've looked at the robotic growth and utilization. We look at this regularly. This will be a dashboard. Some of us may look at this twice a day. I don't know if Jim looks at this maybe 4 or 5 times a day, but I'll tell you, this has been something I've gotten down to 2 times a week to look at it, but it's a dashboard that we've been able to grow and build and see how we develop and grow. And throughout this, we've focused on value and certainly looking at the value analysis committee. That feeds into robotic leadership. So the service line leaders are part of our robotic leadership committee, and that then feeds into our steering team, where we'll meet quarterly as well as the steering team to oversee this. And again, it's a multidisciplinary approach throughout this. What's really different now, having lived this from 2008 to now, is how we've added partnerships. And one in particular is with Intuitive. I can say that they've actually provided a tremendous value. Their core focus is aligned with ours. And it's really great to find partners who have that alignment in the core values of taking care of patients and doing the right thing. And this starts, and this I've seen this through from the team at the ground here in Allentown, all the way up through to the C-suite, in having similar alignments and discussions about value and providing more minimally invasive surgery for patients, because we do believe that provides better care.
So real quick, I just want to weigh in. This is one of the ones where Marty and I felt it was good for both of us to weigh in on. I'm not a paid speaker for Intuitive Surgical, and quite frankly, the opposite. I've worked with Intuitive for the past 4.5, 5 years now, and prior to that in my anesthesia role as part of the robotic leadership team. And I've always deferred on speaking. One, I'm focused on continuous improvement of the program and don't feel we are where we need to be yet. But the reason why I'm speaking today is I think it is important to talk about our vision and some of our successes, as well as where we've hit bumps along the road. And anyone on the line who is purely administrative, as I mostly am today, you don't have very many corporate partners, and I choose not to call them vendors, but corporate partners that come in and they want to understand your vision. It's usually about their vision, and their vision is to sell more products and to become more successful. That has not been my experience with Intuitive, and I've worked very closely with the leadership, like Marty said, locally and regionally, as well as the leadership nationally. And every time we enter into a conversation, they ask about what we want to achieve. What's our strategy? What's our focus? How do we want to move this program forward? Absolutely, our success benefits them and converts into their success, but their approach is a lot different, and their support is beyond different than other vendors. They've really focused with us, and they've been patient along the way. And I know our local leadership team, cringe every time we talk about cholecystectomy. Show me the data. We're going to move strategically. We're going to move slow, and that was not a primary focus of ours. We worked on hernia. They allowed us. They supported us. They worked on some great ideas with us. But they've supported our strategy instead of implementing their strategy, and I think that's what's different with Intuitive Surgical and how we're building this program out.
That's a great point. Thanks, Jim. The times are different as well, and it's as we look at discussions on data, there's a tremendous amount of data. Intuitive Surgical has been the industry leader, one of the only platforms out. There are others coming, and we'll look at those as well. But the bar is set very high, and as a surgeon, we've said the bar is set, but we certainly will keep an open mind as we look at other platforms. But I'm going to show you what we've been able to do with our current platform, which has transformed our community. As we look at data, which we look at regularly, we look at case scheduling accuracy, and that's really something that some of the tools that we've had have really allowed our surgeons, when they become proficient, to have scheduling accuracy, which has been much better than we've ever seen. The costs are consistent across the procedures. Once the cases are, the surgeons are comfortable and again proficient. We monitor our sites of care. We talk about these. We have an exceptional robotic nurse leader as well, and that's a very important position. I'd recommend every institution has, as well as a medical director overseeing this. And certainly we look at volume and block utilization. So that's our 17th Street shift. Looking at Cedar Crest, we've been now able to expand access to the higher acuity procedures. One of the programs we started was a Compass program that we engaged our colorectal surgeons to help develop their skills, partner with them, and see where we can bring more cases over from open or hand assist to MIS and true MIS procedures, and they've been able to do that. We've increased capacity for our thoracic surgery program that will continue to develop as the technology advances in the lung nodule space and image guidance space. We've added an SP to our portfolio for urology procedures and same-day prosthetic procedures and possibly in the future other procedures, as well as ENT. We've allowed for, and this is big, more complex bariatric procedures. We have some exceptional bariatric surgeons at our institution, and they do high volume. What we've been able to do now is having the XIs is to shift the procedures to allow for them to have two XIs and have them the ability to flip rooms, as we'll show you. We've validated that at our 17th site, and now we can effectively bounce them and flip their cases as well. That provides for more access and a more satisfied surgeon and team. And we've increased access for GYN oncology and gynecologic procedures of the higher acuity. So the patients that do need to get done in the surgeon's opinion and recommendation at Cedar Crest will go there. Otherwise, and when I schedule a case, I'll say this is at Cedar Crest or this is at 17th, and make that judgment on the consent forms where we'll go and place that. When we look at the lower acuity volume, hernia screenings, we did hernia screenings through social media on Facebook and would post that, and our surgeons would come in the evening and talk to our community pre-COVID. Now we can do this virtually, but pre-COVID, they would have these sessions, and I'd leave the office and walk by, and there would be 50 to 70 patients listening to one of our general surgeons who's just providing a hernia talk about this technology. Years ago, the general surgeons were not immediately ready to move in this, but with the XI technology and fourth generation, every time I show one of our surgeons the technology, the 3D enhancements, their next question is, how can I be involved? So we bring them to robotic leadership. We shift cases as well. We brought this low acuity now to 17th and grown 26%. So clinical opportunities. We've moved from a mindset to one to many, and that really just has been a transition as a surgeon champion to an executive surgeon leader that I've personally experienced really early on, really feeling that you're on an island and people are saying, why are you doing robotic surgery? There's, some would say there's no benefit, when in fact, in our core values, we knew that do the right thing, and that's what we found early on. We stayed the course and shifted, and what we've been able to do is now identify surgeon leaders in our 11 service lines and partner with them and work with them as well, and now they have been able to develop to a mindset of many, and that's really been personally satisfying to help work with colleagues who would be operating on me if I needed surgery. We've understood what motivates members, what motivates our colleagues is always an important question. At the end of the day, you have to sleep at night. You have to make sure you can close your eyes and put your head on the pillow and make sure that you feel and you did the right thing. And that's our core focus. When people want to join our team, we ask why. And if they do, which they do, want to do the right thing, then we'll have that discussion. We remain laser focused on this as part of our mission. The technology has offered additional ways for us to develop and do a better job as this is developed, remembering back to the older days of the Da Vinci platform now to the XI has really changed that technology. And with that, we have to redefine metrics for success. What was done on an SI is the different time of what's now on an XI. And in the next 5 to 10 years, there'll be additional technologies that are delivered. But it's important to focus on what drives value, and that's patient outcomes, making sure that we provide the best quality of care at the best cost that we're able to for our patients, and continuously reiterate this and look at this and look at our dashboards and try and see where can we improve. Where can we improve? And Jim knows that he'll get a phone call from me fairly regularly about how maybe we can try this and try that. One area that we've done this is developing a brand and marketing our program from a strategic point. Now, let me just caution you, as you start to do this, it's important to have your data ready, because the you want to make sure you publish your data, you know what your outcomes are, and we've had that, and that's why we've been very comfortable in saying our outcomes are better with MIS robotic surgery, and we've delivered that message to our community. We've made sure our content, of course, is convertible to different platforms such as the iPhone, and really incorporated videos as well, but some of these are our own. Some are on the Intuitive website that you can go to. But our surgeons, as we spotlight them, we would bring a marketing local team in. We would ask our surgeons to come in and have a discussion. And you can go online and see we ran a surgical excellence campaign several years ago where we had our number of our surgeons, we recognized that the more you do, the better you are. And we were doing 70% of the volume in our community, taking care of them, so we wanted to let them know. So that's been really important. Another thing that we've done is we've invested in our patient experience, looking at that quadruple aim, the colleague experience and the patient experience. We've started this EASE app, E-A-S-E, which has now been acquired by Vocera. But as you look at EASE, we were one of the first hospitals in the country, really in our robotic service line in our institution, to deliver this. We piloted it with our technology team. It was remarkable to be able to stay in constant communication with our patients all around the world. I'd encourage you to go and look at that, and I don't receive any honorarium or anything from EASE, I will tell you, but it certainly has helped us to stay in touch with patients and been remarkable. I'm going to turn this over to Jim now to talk more about the operational efficiencies that we've done.
Yeah, thanks, Marty, again. So one of the things that, we really need to think about as a program, and I'm sure it's within your programs as well, is that this is not, Marty and myself and a few other people doing this. This truly is a village of doing this, and, I often think that our strategy is only as good as the people involved, and this stems from, our practice leadership, our vice president of operations of our physician groups, and I know Lori's on the call today, and I'm not just giving her a shout out, but without that alignment from the physician groups and the physician leaders, we would not be where we need to be. So we can put all the operational changes, in place, but without true alignment amongst our surgeons, the practice, the clinical folks, the OR team, our turnover teams, and our C-suite, our program's nothing. So what do? We look at block. We look at block on a very regular basis, and I know Marty talks about the data he stares at, but I know myself and my team, all we do is look at data and try to continuously improve. So block changes, they're ongoing. And one of the things that I'll highlight is where I think we had a great opportunity during COVID, and we used it as really an opportunity to improve our program. Culture changes. This is something that, Marty and, his team of surgical leaders do really well, is really engage that team. And when Marty talks about laser focus, it's there. Everyone on that team has that same focus to develop and continuously improve our operations. Training. We make sure that we're doing test runs. Anytime we do a new procedure, Intuitive helps us. They bring in the right people. We bring the right people to them, and we make sure that we're really firing on all cylinders before we launch any procedure or any program. As far as standardization, as we increase the fourth generation technology and some of what you'll see our block model at our ambulatory surgery unit, for the most part with our high volume surgeons, we use flip rooms because we want to make sure that in any given day, we know that it's important to utilize our robots, but it's also important to utilize one of our more important resources, which is our physicians, and taking care of more patients in any day. So as we do that, we knew that we needed more trays. We started peel packing instruments to make sure that our turnover was quicker and we were more efficient. We increased the stock of I&A as needed. We increased our scope quantity because long term, that is a key to success. So a small investment can provide really, really long-term operational efficiencies and success. So what you'll see here on this slide, and it is a little busy, and I apologize if anyone's colorblind like myself, the national average, you'll see a very wide spectrum of what people do in their programs. So when I look at success of decanting our low acuity procedures to 17th Street Hospital, and again, I'll recognize that we have a very large regional program, but I'm only focusing today on shifting low acuity cases away from Cedar Crest to one of our closer ambulatory surgery units. Our profile of cases done at Cedar Crest looks a lot different than the national average today. And that's because we were able to take those low acuity cases in mostly general surgery and gyne, and when I say gyne, it's gyne and gyn-onc together. It's about a 50-50 mix over our ambulatory surgery unit. That allows us to create more capacity, as you can see, for those higher acuity procedures at Lehigh Valley Hospital Cedar Crest. So as we shifted these procedures, we've seen growth. And I'm not going to bore everyone with our success, but about a 63% increase from launch in 2018 to 2019. That has only grown in 2020. We have to exclude the COVID period, but what we've been able to recognize that month over month, with full months and no COVID, we've actually had greater success in 2020 than we did in 2019. So one would surmise if you're taking all these cases out, you have a lot to backfill. So not only have we proven that we can backfill procedures, we've actually grown 10.5% year over year from 2018 to 2019. And we continue to grow with creating additional access and optimizing block to improve access to new surgeons. This is where, and what I said earlier is maybe not the greatest pride in some of what we do. So on Monday, and I know Marty wants to jump in, this is what his day looks like. And I'll let him talk about the personal side of it, but then I'll go to Tuesday and Wednesday. This is where we felt we had the greatest opportunity, because that's not an efficient day for that surgeon that you see as Surgeon B. So what we've done as we restructure, we've created models that are similar to what Marty has on a Monday at our ambulatory surgery unit. And then on Wednesdays, Thursdays, and Fridays, and we only took a snapshot here, we ensured that whoever was going to be using these rooms, we're going to be using them all day and utilizing the systems fully. So that surgeon on Wednesday found themselves, instead of every other or every week block, every other week block. And that's some of the continuous improvements we make. But I'll let Marty talk about the Monday for you.
Yeah, Monday was one of those special days that we've now been able to replicate. I've got 3 kids, and Monday was a day when I had cases scheduled, but we had our teams, we were efficient, and you can look and see that there's 6 cases, and this is just an example of how we started in one room, and then the next case would go, so I would close the skin, go ahead and do our timeout, or do our ticket to the OR, talk to our family, go to the next room, do our timeout, and then start that case, finish that. And I was able to actually do 6 cases and 1 minor here, and personally dropped my children off for school in the morning and managed to pick them up from school in the afternoon. So that I've actually been able to replicate, and I found myself having with one room. I would do 3 or 4 cases and have that window to be able to do additional, and really be like an orthopedic surgeon, which is something that we've been focusing on. The surgeons that can do this model with flip then are similar to orthopedic surgeons in that model. So, of course, Jim, we look and say, okay, 3 o'clock, and depending on our block time, perhaps there's an additional case that now we've added as well. And that's where we look for improvement and say, okay, if the case goes till 5, do we add 1 or 2 more cases? But that's an example of really what we've been able to do to change our outcomes.
So, and I'll touch on a few more things. So Marty talked about, consistent cost. This is where we partner internally, as well as we work with Intuitive Surgical to make sure that we're looking at internal benchmarks for choreography and cost consistency across all campuses, and we've provided that. But we take it a step further to make sure that we continuously press upon our Intuitive colleagues to say, what's best practice out there? We get it. Our case costs are consistent across the board, but is that benchmark outside of LVHN? And we work down to that. And I feel very comfortably when we look at not only INA, but overall direct supply costs, we are definitely in a position that we are comfortable with moving forward to reduce the total cost of care. So this is another number that we're proud of. Since 2018, 1,214 surgeries at 17th Street. We know that this volume will continue to grow as we continue to refine, what our surgeons are doing on a daily basis with the flip rooms. And, I love that, Marty was able to pick his kids up on Mondays. But as we evaluate this efficiency, one of the other things we do is we change our targets. And Marty knows this because he's one of the people that helps facilitate changing these. It used to be 2 surgeries. Then it was 3 surgeries. And then it was 5 surgeries in 2 rooms. Then it was 6 surgeries. Then it was 7. And by looking at some of the data, we're going to be requesting 7 and 8 for certain specialties, and we know over 10 for other specialties. So this number is going to continue to rise dramatically over the upcoming year. So really, what has this site of care strategy enabled? And I really look at the site of care strategy as a foundation for continuous improvement. We're not going to stop. Yes, we're happy and we're proud of the program, but we're not going to stop where we're at today. So as I stated earlier a little bit, we used COVID as an opportunity. When COVID went down, we had daily meetings with surgical leaders, our practice leaders, my entire team, really talking about, okay, how do we ramp down? And the day we ramped down, we started talking about ramping back up. And then we figured out this is a tremendous opportunity. Let's deconstruct all of our block schedules and work with our physician practices to really ensure that we're going to align our OR schedule with our practice schedules. So even outside of robotics, we completely restructured our block. We go live at 2 of our centers in October. We've already gone live with 2 of our campuses in the Valley already due to other factors. And we really ensured that the practice schedules and the OR schedules are completely aligned for success. Our robotic schedule looks a lot different moving forward than it did prior to COVID. And we're truly anticipating at 17th Street and Cedar Crest that we're going to see a 20% increase in volume for the remainder of the year. Ongoing improvements, as I said, I'm not comfortable with, being happy with the program we have. We're going to do more staff trainings. We're going to create that culture, develop more people to support this program because we are running later day by day. We're recruiting new robotic surgeons. I think that's another enhancement of our program because we have a lot of technology and we have the latest technology. It's very easy for us to attract high caliber physicians and providers. We have a resident and fellow program. That's where we're focusing this year, expanding our residency training to general surgery and other specialties as needed. We have a colorectal fellowship that we're going to expand, that we have expanded this to, and really structure and formalize that. SIM now allows us to do that not only with residents and fellows, but also med students and new surgeons who are attending or attending surgeons who are currently on console that want to do new procedures. Having SIM now allows us to do those advanced trainings as well. Again, block scheduling and credentialing protocols, and I'm not going to belabor this much, but this allows us to make sure the right people are operating at the right time and they're doing enough cases.
So as we look to the future at LVHN, we feel like we're just getting started. I don't know about you, Jim, but that's where I feel. I feel like, wow, we're just getting started. We're planning our build out of infrastructure. We're actually building hospitals and planning infrastructure that are in the ground and plan to be in the ground with, to continue to expand the care that we provide. We have additional systems that we're planning at certain sites as well. So that's sort of some of the future, but really what's exciting as well as us just getting started is where the data analytics is going. And Intuitive knows data, the data that they know, they see our data as well, but now the IRIS technology is a new technology that's coming for image overlay. So that's a technology that allows us as surgeons to take CAT scans and overlay them with within the console and then really have some added intelligence. So that's a new excitement that's coming. And then certainly we have upgrades, as we said, there's several SIs that remain, and we're planning upgrades in our northern campuses. All of this will provide a consistent portfolio so that when our employers work with us, when our payers do, they know that when patients come here, they're going to have a seamless, quality, outstanding care that's provided, aligned with our core values that we have, and certainly have that across our entire network. This is aligned with the quadruple aim, really, as we always think about this, but more than that, we focus on our core values as we discussed, and really thinking about compassion and integrity and really doing the right things for our patients. We think about collaboration and teamwork, and an example of Jim and I sharing this with you today, because it is important. We're taking care of people in Allentown, but you all are outside around the country and the world, and making sure that you're able to offer that to your communities as well. That's collaboration. And lastly, it's a commitment to excellence. So the final core value is excel at what you do and do the best that you can and continuously try to improve on your performance. So, those are our values that we have, and we continue to strive towards them.
So I know we're running out of time, and I want to allow time for questions. So just some key takeaways, and I'm sure, most of you feel the same exact way. We really need to, when you build this program out, understand and validate your data, and do it again and do it continuously. That's something that we're very fortunate with at LVHN, is that we are data rich. We have an enterprise analytics team. We have internal folks within surgery. We work very closely with Intuitive to build things out. So really understand your data and use that to drive efficiency and drive success. Be strategic. Without a strategic vision, you have nothing. So understand what your strategy is and have a vision of how you get there. Collaboration and alignment at all levels. As I shared, we were successful as a legacy program, and we've really matured this program over the past 3 years to really build what we feel is a regional model for success, and we've done that with collaboration and alignment at all levels. And then, last but not least, never be satisfied. Focus on continuous improvement. Continue to grow. And then the final takeaway, be thankful for your team. I work with a great team every day within, peri-op leadership. I work with a great team in surgical leadership. Marty as the medical director. Our physician practices, our institute leadership, Dr. Bacala, who's a very well-recognized robotic surgeon, Dr. Pasquale, who is not a robotic surgeon. He was a former trauma surgeon and chair of surgery and now physician chief of the institute. He was one of those skeptics with me, and I will tell you, he is 150% all in robotics now and supports us all along the way. And lastly, thank you to Intuitive and Beckers for having us today, and finally, thank you for everyone who attended. Hopefully this was helpful to you. And we'll turn it over to the moderator and really hopefully have a few minutes for questions.
Yes, thank you, Jim and Dr. Martino, for that fantastic presentation. We do have some time for questions. Attendees, if you haven't posed them yet, feel free to type them into the Q&A box on your screen. We will get through as many questions as we have time for now. So let's see. Some did roll in already for Jim and Dr. Martino. One here says, how do you determine which surgeons get a flip room? Is there a number of cases required per day or a max case times benchmark used?
Oh, wow, that is a great question, and that's not I'm assuming it's one of my peer administrators out there who are trying to manage this. So, that's not a question only for robotic surgery. I think it's something we struggle with all along. And, people with the idea of, 85% block utilization probably should not enter a conversation of what efficiency looks like in a flip room. You're not going to achieve the same utilization per room, but what you have to identify is what is the number of cases, and I should say this is how we identify the number of cases one surgeon can do per day in one room. And are we able to efficiently and effectively use a flip room to either increase it by a certain magnitude of 66% or more, or even double it. So right now we have targets by specialty that we work on, and our only flip rooms today is one of our high-volume urologists who has completely accurate and very easily measurable times. He's very quick, 20-minute nephrectomies on console and done, or less. He's a single port user also, and that allows us to flip him from XI to single port, since that's the majority of our single port volume. Marty's team within Gyn-Onc, they are very reproducible and efficient surgeons and have their console, their case time totally down to about an hour or so. And we require them to do 6 to 7 cases a day, and on many days Marty overachieves, as he often does, and does 8+ and some opens in the middle. Our general surgeons, to get the flip room, need to do at least 8 to 10 surgeries at our ambulatory surgery unit, and in our bariatric surgeries within our acute care hospital, we require 6 or more. Hopefully that answers the question. Thoracic, we do not, because the length of surgery and the amount of turnover time, in colorectal is very similar. I do see that there will be other specialties that potentially could benefit from this in the future, but we're not seeing it today.
If I could just add on to that, what we've been able to do as we started to validate this flip room process, we started in gynecologic oncology and surgery, and we measured our in-room to incision times very clearly as a team. We looked at the incision time to on-console time, on-console time to off-console, and off-console to skin closure, then out of room, and turnover. And we were transparent on walls with our patients. With our staff. Our patients were asleep. But that's how we were able to identify that there's that opportunity for us to be able to have the flip rooms.
Okay, thank you, Jim and Dr. Martino. Another attendee, a couple questions came in asking for some more insights about how you decided which procedures to move to the outpatient setting, and also specifically if there are any written guidelines that you reference to help determine which procedures go to outpatient settings.
Yeah, so this is a really great question, and one of the things that I wish we would have had more time to focus on during your presentation, but we really wanted to cover it all. So I'll go this way. We worked with surgeons who we knew were going to be champions early on. We also looked at the data. Which surgeons had patients that were going home same day, within 12 hours from admission to discharge? Was it reproducible? ASA classification, all the medical comorbidities. But at the end of the day, we worked with the surgeons, and I don't want to use the word entice, but we enticed people to a highly efficient center that was an ambulatory surgery unit versus a level 1 trauma center that is much bigger and has more complex to navigate for our patients and our surgeons, and provided them a better experience. So it was based on clinical factors, efficiency factors, as well as providing them with a better environment to be successful. But we did not discount, nor did we ever not look at clinical factors, and we worked with our surgeons. We didn't strong-arm anyone, but I will tell you there were times for the efficiency of the program that we utilized a combined tactic to say, this makes sense, and we had support from medical directorship as well as overall surgical leadership said, this makes sense, let's give it a try, and we continuously monitor it. We look at our outcomes, we look at our pain scores, we look at our readmissions, so we know that we were making the right decisions. And this wasn't done overnight.
And as one of the surgeons being part of that, I would say that it was really a partnership. It was I never felt that it was a strong arming. It was more of, do you think this is something you'd be able to do? And what cases do you think you'd be able to move? And operationally, how would we be able to do that? And that's how we started. And once our GU oncology team and surgery teams, as we started there and said, we can do this, we recognized, wow, we now are able to increase access for our patients. They're happy, our physicians are happy, and our community and our hospitals happy as well. So it really was a win-win-win moving to that model. And I think, Jim, we're going to be looking for there are additional surgeons. They continue to ask, can we have another flip room? Well, there's some of these metrics that they have to do. That operative time has to be in that operative to non-operative ratio, if you will, for them to be able to do that.
Okay, and this will likely be our last question for today, but this attendee asked, did physician recruitment play a significant part in bringing in robotics-trained surgeons, or did existing surgeons want to be trained?
Both. I mean, that's an easy answer in my mind, but I will tell you that we've trained surgeons who were on board, and obviously the program started in 2008, so everyone's had an opportunity. We've actually seen surgeons train, not use, lose privileging, and then as this evolved, and I'll speak about our bariatric program, as Dr. Martino said, we have a high-volume bariatric program and 3 dedicated bariatrics just at one campus, and these guys are high volume. The one surgeon who trained years ago, who gave up privileges just about a year ago, knowing that we created this efficiency model, added 4th-generation technology, and we've continuously refined our block to provide a very efficient environment for him, and he's one of the surgeons that has had block reassigned, so we can do a minimum 6 sleeves or a combination of sleeves and roos in one day and got that back. But we've also used this technology as a recruitment tool. We have a lot of technology, as Marty highlighted. We have 11 systems in a fairly reasonable geography, but it's not far. We have a lot of 4th generation. We're going to complete the 4th generation in the upcoming year. And we also have SP technology, and we work very, very closely with Intuitive Surgical to make sure as technology comes out and we feel that it's valid, that we push to get it here. And that alignment with the Surgical Institute, really focusing on innovation, makes it a lot easier for us to work with Intuitive and our partners.
Okay, well, the attendees, thank you so much for your questions. and for your engagement today. And I want to thank Jim and Dr. Martino as well for an excellent presentation, and to Intuitive for sponsoring today's webinar. On behalf of Becker's, we hope you enjoy the rest of your day, and we look forward to having you join us for future webinars. Thank you, Jim. Thank you, Dr. Martino.
You're welcome. Thank you, everyone. Thanks, everyone. Bye-bye.